the new oral anticoagulants, and I think the one thing that we would probably say about them is it's about time. You know, the whole idea about replacing traditional anticoagulants, you know, we see that after the first Thanksgiving, the Indians say that was nice, but we don't want to make it a regular thing. Well, we do want to make this a regular thing because a little bit. In 1920, the cattle in Wisconsin were eating sweet clover. And the farmers, Madison, yes, I know, once a badger, always a badger. And so they were eating sweet clover, and they began to notice that the cattle were dying. They were bleeding internally, and people said, well, geez, what's going on? So this farmer took his cow in to Madison, and he took a bucket of blood. And he said, look, this thing is not clotting. And there's this guy, Carl Link, a good badger guy, and he said, this is nuts. What is this? So then he began to look at it and eventually came up with the fact that what was killing the cows was something in sweet clover, which they eventually isolated, and they called it Warfarin for the Wisconsin Alumni Research Fund. How cool is that? Yes, yes. And my office was in the Wharf building, which is Wisconsin Alumni Research Fund. And so that's 1954. That was a year before I was born. 60 years ago. It's time for something new. This is what we've been using. We've been using a 60-year-old drug all this time. It's time. So let's take a look at this case. There's a 47-year-old lady who came to see me. In 2007, she was found with a left kidney mass, and she underwent a left partial nephrectomy. She had a DVT in her left arm. Now, anytime you see a DVT in the upper extremities, it's pathologic. People don't get clots in their arms without something being there. She was found to have heparin-induced thrombocytopenia, had a pulmonary embolism, and she actually, all these complications, she was hospitalized here at St. Francis for 2.5 months. She developed a DVT in her left lower extremity, had a lot of complications, multiple ongoing clotting, trouble after trouble. She was anticoagulated with Coumadin, very hard to get therapeutic times, and that's the key with Coumadin. Remember our 60-year-old drug from the farmer who couldn't understand why his cows were dying. And so very hard to get therapeutic times with these things. So what they did with this lady is they kept cranking up her dose of Coumadin. And they kept giving her higher and higher doses to try to get a therapeutic PT-INR. When she came to me, she was on 30 milligrams a day of Coumadin. When you're on such a dose, normal is about 5 milligrams. When you're on a dose like that, that stuff begins upsetting your stomach. It gives you stomachache. Her PT-INR, her physician was asking her to test her PT every day because he couldn't control it. Every day. She was going and she was really having a hard time because her insurance wouldn't pay for daily PT-INRs, so she was having to pay for it herself. She was very worried because she was having all this financial trouble for her daily PT. She was taking greater than 30 milligrams of Coumadin a day. It was upsetting her stomach. Her appetite was, her quality of life was not good. And she came to see us. And this is sort of like the New England Journal of Medicine where a diagnostic procedure was performed. So we'll leave that for the end. So what's wrong with Coumadin? Warfarin, of course, thanks to the badgers, has a narrow therapeutic range. Slow onset of action, slow offset of action. That means when you stop Coumadin, it takes a while for it to eventually go. The dose change that you make in Coumadin today, you do not see it reflected into the PT that you draw 48 hours from today. Has a long elimination half-life. It has all sorts of interactions. You can't eat asparagus. You can't eat spinach. Monitoring is required, difficult to manage. You've got to poke people every day, invasive procedure, impaired quality of life, labor intensive for the healthcare providers. What would be the qualities of a new ideal anticoagulant if we were to find one? Well, we get one that would start quick, that would stop quick if we need to do surgery, that would have a predictable therapeutic effect, that would have no food or drug interaction, that would not require any monitoring the way Coumadin now does, that would have well-defined pharmacokinetics, that if somebody has kidney or liver disease, we would know exactly what we need to do in terms of tapering their dose, that would be easily reversible if they got into trouble and took too much of it. It would be, of course, in this day and age, cost effective. So let's take a look at some of these new ones that have come along after 60 years of Coumadin. Now, we're going to take a look at the good old clotting cascade, which has changed very much in the last 5 years. But there are two basic classes of these new oral anticoagulants. One is a direct thrombin, i.e. factor 2A inhibitor. It's called Pradaxa or dabigatran. Then the other two fall into this category. They're factor 10A inhibitors. One is Rivaroxaban and Apixaban, Eliquis. Now, I would say the one that you need to just bear in mind is this fellow, the one that begins with the letter X, Xarelto. And this is the one that's winning the race. Just so that you can see, this is the way that more and more they're asking us to look at these things. There is activated factor 10, and these two guys block factor 10 so that this guy can then not stimulate prothrombin to become thrombin, i.e. prothrombin is factor 2, to become activated factor 2, which is then called thrombin. Then this guy lets fibrinogen become fibrin, and there's our clot. I, of course, being not a young chicken, I prefer to look at it the old way. And we remember there's this very long, convoluted intrinsic pathway, and there's the quick and easy extrinsic, but they all meet here at factor 10. That's where Apixaban and Rivaroxaban, remember these two guys, and that's where these two guys gather, and they block the cascade here. Now clearly, whether we're coming off the intrinsic or the extrinsic, if we stop the highway there, well, there's no cars going after that. And if we didn't stop it there, well, we can certainly stop it here as Pradaxa does. Now, let's take a look at the first of these three new oral anticoagulants, Pradaxa. It is the only direct thrombin inhibitor. Remember, this is the only one that blocks at that point. The other two guys block factor 10A. And here's the key. Its maximum anticoagulant activity occurs in 2 to 3 hours. That's impressive. Any idea how long it takes Coumadin to work? 72 hours. You know, we have people, we bring them in, we give them Coumadin, and then we wait 3 days. And the clock is running, the people are saying, when are you going to discharge him? This is 2 to 3 hours, it starts to work. That's both a good thing and a bad thing, we're going to see. A half-life is 17 hours, but here's the key, BID dosing. And that's a problem, because BID dosing means that if it goes to work so quick and you forget to take it, it stops working and then you're in trouble. 150 milligrams BID is a typical dose, hepatic conjugation. 80% of it goes out by the kidneys, the rest goes out by the liver, and because of that, it's contraindicated in people who have less than 30 creatinine clearance. Nausea is really the only side effect. It's pretty harmless. I've used this plenty. It's a very good drug. The only difficulty is the BID dosing. Interactions. With food, none. You can eat whatever you want, not a problem. It does interact a little bit with PPIs. It decreases absorption by 20%. Amiodarone cranks it up by 60%, so that's one interaction. Doesn't have any interaction with cytochrome P450. We're going to see that the other guys do. It's contraindicated, by the way, in people who are on verapamil, rifampin, clarithromycin, and quinidine, because these are things that actually will decrease the effect of it. There is no antidote for an overdose, and that is a main worry. Everybody always says, well, geez, how can I know if it's working? We're going to get to that at the end. There's no overdose, so how can I reverse it? Actually, it's not true that there is no overdose, no antidote. We'll talk about that. It is dialyzable if somebody takes too much, but it's cleared quickly. 17 hours, it's a half-life. So if you can get them through and they're not bleeding, you can support them. in a quick time it's out of their system, which is a nice thing about all of these new drugs. No longer that you have to stop it and wait 5 days before you can do surgery. You can stop it today and do surgery tomorrow, which is what we've been doing. Indications now, these are the official indications, but we of course know that we could use it for DVT. We've been using it. AFib, not due to a valve problem, approved by the FDA in 2010, reduces strokes, and also decreases the risk of DVT recurrence or pulmonary emboli. Just this past April 14, the FDA approved it for that. Now, we see that some of the studies that were done, this is what you will have in your handouts. What I've done is I've made sure that you have all of these studies in your handouts, because the studies are what you need. It's the things that you will be able to then look at. But rather than go through a whole laundry list of studies here, I've summed it up here, but given you the studies in your handouts. So this is one where we looked at Pradaxa versus Warfarin for treating thromboemboli. And this one was called non-inferiority, but we know it is just as good. We know that it is at least found to be not worse. The main thing is I want to point out something. This is good old USA Today, unfortunately. Look at the bleeding events. Fatal number. DABI is dabigatran. That's what we're using. These guys, I guess they thought they were cool by just calling it DABI. And so the fatal bleeding events, 1. Coumadin, 1. Warfarin, thanks to the Badgers. Bleeding into critical organs. Coumadin, 9. Dabigatran, 1. I think you get my message. This guy, not a whole lot of bleeding there, right? But that didn't stop this from happening. $650 million to settle 4,000 Pradaxa lawsuits. Why? Why? Because they were told, oh, you won't bleed. Now, everybody knows that with Coumadin you bleed, and people are just, well, it's an old drug, so I bleed. But because they set the bar so high for poor Pradaxa, some lawyer bought a new car.
Very nice one.
A very nice new car. It's wrong, but unfortunately is the reality we live in our litigious society today. That's why I would say to you guys, be very careful how you do things. That's why we're going over this like this, and you've got the studies to back up what you do. Unfortunately, the reality is that we live in a litigious society. Now, you can use Pradaxa for a long time in venous thromboemboli, and it works very well. You can stay using it. This study, actually, people were on, there was another study, another slide that I took out for the sake of brevity. This showed that you could take it for a year with no side effects. Now, the next one, for the sake of time, is Xarelto. This is the one that you guys would want to become familiar with. This is the one that's winning the race. It's like in the old days, if you're as old as me, you remember that once upon a time, it was either Betamax or DVD. And DVD won. Rivaroxaban is the DVD. This is the one that's winning the race. It's a direct factor 10A inhibitor. We remember from the previous slide that how does that work? We remember from our center that this is the guy that blocks this here, along with the last guy who we will see called Apixaban. It blocks it there. The only guy who blocks thrombin is the one that we just saw, which is Pradaxa. And so, 2 to 4 hours. You take it now, 2 to 4 hours, it's working perfectly. That's just impressive compared to what we came up with at the UW. Half-life, 9 hours. You take it, here's the key, once a day. That's the key. The key is that the other 2 are 2 times a day. You've got, who gets DVTs? Older people do. They've got a ton of meds to take, they forget to take it, and by the time they forget their second dose, they're not anticoagulated any longer. That's the problem. This is as close to Coumadin as we've gotten. Why? Because of this. Here's where their scientists hit a home run, once a day. Remember this medication, this is the one you want to take home with you. Once a day. 20 milligrams, once a day, you're good to go. the little old lady or old fellow only needs to remember it once a day. Doesn't cause any side effects. They can eat whatever they want. They have no interaction, really not much interaction we're going to see. It goes out by the kidneys, of course, a little bit out in the bile. So that means if your creatinine clearance is greater than 15 but less than 50, then you've got to decrease the dose, of course. But by and large, it's where we want it to be with anticoagulants. Once a day, set it and forget it, you're good to go. Now, interactions, you take it with food. Totally the opposite of Coumadin. Oh, geez, can I eat my asparagus? No, take it with food. It actually works better. Medication, proton pump inhibitors, everybody these days is on Pepsid. No interaction. You can take all of the PPIs you want. Now, of course, things that increase CYP3A4, we know, all of these guys, ketoconazole, these increase the level. So these are, but look at the list. The list of things that interfere with Coumadin is just huge. I mean, I'm a hematologist, and even I have to look it up. Geez, I wonder if this is one of those that interferes. You only have to remember 4. When things are only 4, that's a board question just waiting to be asked. And so the good news, though, is you only got 4. Antidote, no antidote, but I say no because that's the party line. We're going to see later that there is, but not really. Unfortunately, it is not dialyzable. So that if somebody says goodbye cruel world and takes a whole bunch of them, we have a trouble stopping it, but we can. It's cleared out of the circulation in about 9 hours, though. So it's not that hard, even if somebody tries to overdose on it. Indications. These are the FDA approval. Here's another nice thing. Look at this middle guy. Treatment of DVT. This is the only guy approved for treatment. The other 2 guys, you'll see they have the top one for AFib not having to do with valves, prophylaxis of DVT, fine. Treatment of DVT. This is the guy that's winning the Betamax and DVD race. Treatment of DVTs. This is the guy. Oral Rivaroxaban, we call it Xarelto. It's a whole lot easier for venous thromboembolism. The study that put them on the map is called the Einstein study. A lot of it was done at Einstein University Medical School in the Bronx. I was there giving a number of lectures back in the day. And so these studies, you can see that these are not that, these are 2010. This is all very, very current right now, guys. And this is the Einstein study. Look, they put people on Xarelto. They compared it to even to Warfarin. Here's the thing that I want you to look at. Major bleeds. No chance for the lawyer guy to buy another new car here, you see? Same. So the key is that it's once a day, easy to take, no interference with proton pump inhibitors, starts quick, stops quick, and no major bleeding. This is as good as it gets. And by the way, I have no stock in this company, so it's okay, it's okay. Here's where I wanted to bring you guys. Again, they like to be cool and call it Riva instead of Xarelto Rivaroxaban. Here's the key. The point that I'm trying to get at is that if you look at the non-relevant major bleeding, 8 and 8, which is what we saw in the previous slide, this is where this 8 comes from. But the key is if we look at major bleeding contributing to death, 1, whereas Coumadin 5. This is why our lawyer friends couldn't grab onto this guy and cause trouble like they did for Pradaxa, you see. And so oral Xarelto for DVT, that's why they got approved. This one is the one to take. There's the extended Einstein study. Look at the bleed again. 0.7, not enough for the lawyers to latch on. So you do not bleed with this. You take it once a day. If you want to give a non-Coumadin agent, Xarelto is the best one to take, once a day. Now, let's look at the last guy, Apixaban. And I'm not forgetting the clock. And so direct factor 10A inhibitor, we remember that this does the same as Xarelto, factor 10A. And so the activity here, you give it 3.5 hours later, it's max. It's good to go. That's impressive if you think to yourself, Coumadin, we had to wait 3 days. You don't even know the effect on the pro time until 2 days after you give your dose with Coumadin. Here, 3 hours, you're set. Unfortunately, this is the problem, twice a day. Xarelto once a day. Typical dose 5 milligrams. CY3A4 again, so it interferes with those. 25% out the kidneys, 75% out through the bile. You decrease dose, and here's another reason why this one is very much not winning the race. After 80 years of age, that hepatic excretion doesn't do so well. And so in people who are over 80, you have to decrease the dose if they weigh less than 60 pounds or if their creatinine clearance. But let me just see, who gets Coumadin or anticoagulation? People over 80. By the time they're over 80, they usually weigh under 60, and many times their creatinine clearances. So these are exactly the same people who usually get anticoagulated, the ones that you wind up decreasing the dose. So this fellow is not exactly winning the race. Interactions, no food interaction. Proton pump inhibitors, no, but we do have the usual set of agents that interfere with it, that increase the cytochrome P450 set. It increases the level if you take one of these by as much as almost 100%. Well, nobody really, we still use some erythro. It's less expensive clarithromycin we do. Rifampin if you've got TB, of course, but there's a lot of people on Tegretol and Dilantin. Good old St. John's wort drops your levels by 50%, and this is the interaction that we saw before. Again, the party line is that there is no overdose for antidote for overdose. It is dialyzable in about 70%, but it's cleared out of the circulation in about 15 hours. Indications, remember that what we saw for Xarelto, we had the top, we had the bottom, middle, no middle. Treatment for DVT is not approved. So we got the valve, the AFib with the valve, the DVT prophylaxis, but treatment for DVT, Xarelto is approved. The other two are not. There is Eliquis for extended treatment of venous thromboembolism. It works very well, and here it is. Here's the key that I would like for us to look at. Look at the bleed. You can give it in the lower dose, 2.5, double, 5, and your bleeding does not go up, as happened with Pradaxa. Okay, need for monitoring. Here's where we needed to get to. Why? Who and why to monitor? Because what if you give it to someone who is very, very skinny? Then you're wondering, geez, should I still give this person? Like in this one, do I give him 2.5 or do I give him 5? Which one do I give? Pediatric, how do I know? I mean, we don't really anticoagulate pediatric, but if we have to. Patients with kidney or liver problems, somebody who decides to take a whole large amount, how do we know how much they've got if we can't measure it? So we want to find out if they are taking their medication. We know with somebody with Coumadin, just check their pro time. To see if somebody who's got a thrombotic or a bleeding problem, is it because they're not taking their medicine is not working? That's why we would like to be able to monitor, but these new medications are hard to monitor, as we're going to say. So if we try to monitor Pradaxa, PTT, the relationship is nonlinear. So the more you give, the more the PTT is not changing. So you can't use it. Pro time, it's the least reliable of all tests to try to figure out what's going on with Pradaxa. The activated time, similar to PTT, it's just not linear. So it's really not useful. Thrombin time is sensitive and linear, not available in many places. Here's the new one that's coming up, and more we're seeing it. It's called the Eckerin clotting time. It's the best, but it's slowly being adopted because we need a way, remember why? Because of all of these reasons, to be able to monitor these things. Right now we know that we give it and it works, but as physicians we have a hard time with set it and forget it and don't ask me why, just give it. That's hard. because we come from science. If we, you know, the old joke that the normal person sees a match and touches the match and burns himself, says, "Ooh, boy, that hurt." And the scientist sees a match, touches the match, burns himself, and says, "Ooh," says, "Boy, I wonder if it'll happen again if I touch it a second time." So we are prone to wanting to get answers to things. And so it is hard for us to say, just take it and don't ask me why. Just take it. Trust me, it works. It's very hard. So we want to be able to know. There's something called the hemoclot thrombin inhibitor assay. It's really a dilute thrombin time. It is sensitive. The V didn't make it there. And standard reagents, it is coming up. Now, if we try, this is our good guy, Xarelto, the one that is now getting to be more and more used. The PT, the effect is transient and changes over time. It's not reliable. PTT, it's actually weaker. The activated time, no information on its effect. There's this thing called the HEP test, clot-based anti-factor 10A. It's got paradoxical effects. We thought at one time this would be a really good one, but it is not yielding that. Prothrombinase-induced clotting time, again paradoxical. Anti-factor activated factor 10 assay, sensitivity varies. There is one commercially available assay that appears to be able to detect it slowly coming up. This, I think, is going to be our winner. So we can be able to say, this is how much this fellow has in his or her system. To be useful, we have to develop standard curves. This fellow is, I think, going to win. And then lastly, we have the newer guy, which is this Eliquis, Apixaban. PT and PTT, minimal effects on these tests. Factor 10A may detect, still not clear. Pretty much, we have no real good way to monitor except for this test that's coming up. So, what are the advantages of these new medications? You give them orally. They start real quick, which is wonderful. They may replace IV anticoagulants in certain situations. They may eliminate, they absolutely do eliminate the need for heparin followed by Coumadin. Anybody know why we bridge heparin and Coumadin that way? This is always the million-dollar question.
We've always done it that way.
Exactly, exactly. Because we don't ask questions. Your father told you to do it. Anybody know why do we bridge heparin and Coumadin? Whenever you go, somebody says, "Oh, no. Give the heparin first, and 3 days later give the Coumadin." Or give them both, but make sure you got that heparin. Anybody know why?
Because it increases clotting.
Exactly. Why does it increase clotting? Why?
Isn't it?
I can't hear you.
Protein C and protein S.
Protein C and what happens with protein C and protein S?
They actually have a short life compared to.
He's there. What's that?
They're actually anticoagulants, so you inhibit that, you're procoagulatable for like a certain period of time.
He's going to get a good score on his boards. What happens is protein C and S are also vitamin K dependent. So which are the factors that go down when you give vitamin K inhibitors? Coumadin. 2, 7, 9, and 10. And CNS. 2, 7, 9, 10, CNS go down. What happens though is that CNS are anticoagulants. But when you drop C first, S remains and is hypercoagulable. So when you start Coumadin, there is a window at which time you don't have the protection from C, and S is making you hypercoagulable. And so during that initial time is why you want to bridge it with an antithrombin 3 stimulator, which is heparin. That's why we give that bridge. Because there is a period of time when you've dropped one, either C or S, and the other one is making you hypercoagulable until you drop that one as well. Do you follow? So that's the bridge that we no longer need to do here. Because you start it, and it works in 3 hours. You no longer have to wait. There's another important reason to remember. I had another slide. I pruned a lot of slides last night. It's the half-life of thrombin, which has a 20-hour half-life. It lasts a long time. And that's part of the reason why it becomes hypercoagulable as you deplete those with the shorter half-life. These new agents have a predictable therapeutic effect. There's no routine pro-time checking needed, no food interaction, short half-life. They are more convenient for the physician and the patient. We see that commercial on TV, the guy that says not today and makes a left turn instead of a right turn. Possible superior safety and efficacy. Now, what are the possible disadvantages? You can't monitor. You can't titrate it. Well, we've got to give you a little bit more because you're heavier or you're skinnier, a little bit less. Difficult to determine if somebody is poor compliance or if they're just simply not taking it, or if it's not working for them. Short half-life, so if you've got an elderly person who forgets to take his or her medication, they quickly become anticoagulant. No antidote. I'll show you in a second that maybe yes. No monitoring lab, and the dose adjustment for liver and kidney are difficult, and as all new medicines, they're expensive. This is a little bit of a summary, and the key is that here's good old Warfarin. Xarelto inhibits factor 10A, Eliquis factor 10A, and Pradaxa is direct activated thrombin inhibitor. Half-life, about 4 hours, about 8 hours, 9, about 8 hours. 40 hours. No need. Once a day is the key for Xarelto. Excretion, assay, and they, of course, interact. This one with PPIs, which is the most difficult thing with Pradaxa, not to mention the fact that it's twice a day. Now, our center, we are the Comprehensive Bleeding Disorder Center, and we're here in Peoria. And our initial case study is because you remember the case we presented in the beginning that was so hard to control, and we said we'll tell you about it at the end. Turned out that the reason she was so hard to control was because she had P. vera. So she had hyperviscosity. And so that's why all of the Coumadin in the world was not anticoagulating her. And so when we just started phlebotomizing her and her clotting went away. But had she been on one of these new agents, she would not have needed to be all this testing, daily testing, and 30 milligrams. We would have been able to just give her Xarelto once a day and know it's working. And she wouldn't have been through all of these difficulties. Now, what I did want to say is that now there are these things called these activator complexes where we can give a combination of clotting factor, literally like a slurry with thrombin and all these things, that we can try to give it to try to reverse people who are one of the newer agents. There are more and more of these prothrombin complexes that we can now be able to give in an effort to reverse these things. And they do work in large doses and if we need to. So whenever we say that there is no antidote, that's what you need to put on the boards. But in reality, in a pinch, we can use these prothrombin complexes, and they do work. And so I think I didn't do too badly with the time. I think we're good. Thank you very much.